You reckon we get started, Hayley? Excellent. So, hi everyone, and welcome. My name is Sam, and I'm the Business Development Manager here at Team Medical. Thanks for joining us for today's webinar, Walking the Line, Effective Management of Diabetic Foot Ulcers. Firstly, in the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So at Team Medical, we believe wound care is more than just products. It's about education, awareness, and empowering healthcare professionals like you who make a difference every single day. This week is also Wound Awareness Week, a time to highlight the importance of proper wound care, share knowledge, and support patients and professionals in the field. We'd like to extend a big thank you to Smith & Nephew for making today's education opportunity possible, and we're pleased to have Angus from Smith & Nephew joining us online today. Before we get into the presentation, we just have a few housekeeping rules or items. To limit disruptions, cameras and mics are off, but you're welcome to ask questions and participate via the chat function. And please submit your questions in the chat. Hayley will answer as many as possible during the Q&A section at the end of the webinar. This session is being recorded, so a link to the recording will be emailed to you tomorrow, and it will also be available on our events webpage. And before you head off, we'd love it if you could take a moment to complete a short survey, because we really value your feedback. So now I'm pleased to introduce today's speaker, the fabulous Ryan from Wound Rescue. With over 20 years of nursing experience and a passion for wound care, Hayley is a leader in the field and the former chair of Wounds Australia. After Hayley's presentation, we'll briefly explore Smith & Nephew's wound care products before diving into the Q&A. Over to you, Hayley.
Thank you so much, Team Medical, and to Smith & Nephew for hosting a very topical discussion today, which is walking the line, the effective management of diabetic foot ulcers. What I want to really dig into today is some practicalities. I have to be completely frank with you. I only have a very short period of time to talk about such a big topic. We usually spend days talking about diabetic ulcers, but I'll do my best, and I'll do my best to answer your questions at the end. Just a quick disclaimer, you will be seeing some quite graphic photos today. Just a warning, I do have permission to share their stories and the photos so that you're aware. In terms of what I want to take you through today is how to describe and how to think about effective offloading and wound care strategies, what you need to think about when it comes to recognizing the signs of infection and when to escalate those issues, recognizing common risk factors, and then eventually we'll get down the line of applying evidence-based practice. But let's take a look at some statistics. Around Australia, we have close to 27 or just over 27 million people in our population. The reality is we have around 3.8% that identify as First Nations. And when it comes to all of this population, those living with diabetes is around 1.5 million people. But the sad reality is from the population, we're looking at around 300,000 people every year suffering from a diabetes foot ulcer. Now, why is that concerning? Well, if we think about the global statistics, one person every 20 seconds will have an amputation from a diabetic foot ulcer. Just take that in for a moment. One person every 20 seconds will have an amputation because of a diabetic foot ulcer. And around 10% of those with a diabetic foot ulcer will unfortunately die as a result within 1 year. But there is a population in Australia that suffers most, and that is our First Nations population. We still have disparities in gaps around what we know as age gaps. So for example, you can see on the screen, there is still around a 10.6 year gap for males in terms of life expectancy, and still close to 10 years for females. Now, when it comes to the prevalence of diabetes for First Nations, for non-First Nations, it's only around 4.2%. But let's have a look at what happens to those living with diabetes who are First Nations. That escalates to around 11%. So we certainly have disparities, and some of that is because of access. Some of that is because of inability to have support such as from podiatrists or local healthcare providers. So we have some issues around our country. Now, what is a diabetic foot ulcer? Well, by the definition, it is an open wound on the foot. And how it occurs is ulcers commonly occur when bleeding develops beneath a callus. The callus then wears away and exposes what you can see here in this photo is the deeper tissue. So here's a hemorrhagic callus. So you can see the bleeding under that callus. And now when it's opened, you can see the wound and the callus is still clearly around that area. Why do ulcers occur? Well, there's a number of reasons. Peripheral neuropathy and PAD, they're the main drivers. Minor trauma from footwear or pressure, which can lead to callus because of that constant friction, that constant rubbing, which can cause a hemorrhage underneath, as we've just said, and then turn into an ulcer. And I want to just push the fact here, guys. The simplicity here is to start looking at your patients, focus heavily on health literacy around selecting the right shoes. If I think about, say, an aged care population, when I'm walking into aged care homes and I'm seeing a lot of patients shuffle their feet with those ill-fitting shoes, we know calluses are going to form. And if they have diabetes, they are at a higher risk. And as I alluded to just a moment ago, rural and remote Australians and First Nation peoples do face higher risks due to access barriers. Now, my next slide, everybody, just be mindful, these are very graphic photos, but I do it for the purpose of why you're all here to learn more about diabetic-related ulcers. So the question is, how do we know what a diabetic-related ulcer is? Well, there's different types. And I'm going to start with your neuropathic diabetic foot ulcer. That's around a 35% prevalence rate. And how they generally look is they have this very clear granulation, as you can see in the middle of that area, and the calloused borders. So it goes right around the area. These wounds are often, feet are often warm with a bounding pulse. They're typically on the plantar surface and they're usually painless. When it comes to our ischemic diabetic foot ulcers, the prevalence is around 15%. They're often necrotic. They're commonly at the toe level. They can be very painful. And the other clue for these types is that there's no or very, very weak pulse. Now, fair to say, this is a very advanced ischemic diabetic foot ulcer. But, even just a few toes exhibiting a similar look can be very problematic and still enters into that diagnosis of ischemic diabetic foot ulcer. Then we move over to our neuroischemic diabetic foot ulcers. This is around a 50% prevalence rate. They have poor granulation. So take a look at the one on the screen here. It looks quite pale. It's not, granulation should look nice and pink and healthy. And that's how you know there's good blood flow and it's going to heal. This one's quite pale. And the margins of the foot and toes is where these usually occur. The foot is often very cool. They can have a weak or absent pulse as well. They can be painful and they can actually have minimal callus. So the hallmark features of all diabetic foot ulcers is often a callus which sits underneath or hides that bleeding underneath the area, as you can see on that picture there. Now, if you happen to have gangrene and infection, please don't try and treat these wounds. These patients need emergency services urgently. So if you suspect gangrene and infection, don't delay, get them off to the emergency departments. Now, when you are thinking, is this wound that I'm looking at a DFU, you need to rule out all potential other causes. For example, just because they have diabetes doesn't mean that it's not, for example, a venous lower leg ulcer or venous insufficiency, which often happen in that gaiter region. They often have that hemosiderin staining, the jagged edges, etc. And so you need to rule that out generally with a Doppler TPI or ABPI to see what's happening. You should also exclude pressure injuries. Now, they often happen over the bony areas of the foot. And then you've got to think, has pressure been applied, which could potentially be causing that wound? You need to rule out, is there any malignancy to what you're looking at? For example, has it been there for some years? Maybe it's had a very fast presentation. It could look a little atypical. And also vasculitic ulcers, which are often irregular, painful, and they do have inflammatory signs. Now, in Australia, we do follow many guidelines, and I would encourage you all, if you do want further guidelines, head over to the Diabetic Feet Australia website. They have listed all of the evidence and research that you need to know. It's a great little resource website. But the one that we use in Australia is called the SINBAD. And what the SINBAD focuses on, it really just streamlines or structures the way you should assess DFUs. So, for example, you start with, what site am I looking at? I mean, is it a diabetic foot ulcer if it's on the elbow? Absolutely not. So it will take you through a process. What is the site? Is there signs of ischemia? Is there signs of neuropathy? What is the perfusion like? Take the pedal pulse, take the medial malleolus and go up the leg. Is there any diminished or weak pulses you can feel? And go back to the slides that I said a few moments ago and start ruling them out. Are there signs of infection? And most importantly, does it have a depth? And if so, how deep is it? Now, at Wound Rescue, which is the company I operate nationally, and we see everybody outside of the hospital setting, we provide resources to assist clinicians, such as this basic foot assessment checklist, which is based off the evidence. If you wish, I'm happy to put this on our resource page on our website, which you can access and download for free if you feel it would be helpful. Now, when it comes to identifying the risk in Australia, basically any patient with diabetes becomes a risk factor. And every person with diabetes should have their feet checked at least once a year as baseline screening by specialists. And what I'm talking about there is podiatrists. Get to know who your local podiatry services are, because they will be able to do full assessments of these patients and come up with a baseline and recommend how often they need to come back. Now, what they will do is they'll start to palpate the pedal pulses, as we said a moment ago. They'll check the circulation. They'll check for PAD, peripheral arterial disease. They'll test for loss of protective sensation. So we will often use monofilaments and tuning forks, and we'll look for pre-ulcerative signs. For example, any patient who's got a callus is already a red flag for you if they have diabetes. Do they get regular blisters or fissures or nail problems? And then what they'll do at baseline is determine on a scale that they will use what is the risk factor. And you can see them on the screen from 0 to 3. With risk factor 3, where they've had previous ulcers or perhaps an amputation or end-stage renal disease, that patient will be recommended to see a podiatrist every 1 to 3 months. So it is crucial that we go through this assessment. Now, when we do look at these assessments, we also need to factor in other things that need to be well documented. Do they live in a rural or remote location? Is cost a factor? What are the cultural considerations? Do they have limited access to a podiatrist? And we know around Australia, there's just not enough podiatrists to get to everybody. And of course, keeping in mind that the higher risk population, being First Nations, should also be clearly documented in your systems. There are early warning signs to act on, and I've given you a couple here. So I've mentioned callus this entire presentation, but also fungal infections. Nail pathologies. A good clue to potential risks down the track is those ingrown nails. So keep an eye out. Is there redness or hemorrhage under that callus? Is there new swelling, heat, a temperature difference? These are all early signs to act now. Now, if we do have patients that fit this category, and we need to act on offloading, because we know, even with our pressure injury management, that offloading is the best medicine. Well, can I tell you, it's even more crucial for our diabetic patients. And so when it comes to offloading, there's some higher level offloading that's recommended, and these are generally done by a experienced podiatrist or a high-risk foot clinic. And I'll provide in the next slide a few that you can do as general clinicians to support that offloading. Now, for example, here is one which we call the TCC, or it's an irremovable walker, whereby it is fixed. It's fixed in place, it's casting, the patient needs to wear it for the entire time. Now, in fairness, not every patient will be comfortable with this. It may be restrictive. Now, if you have to, we do drop down and we start to look at some other potential offloading devices. For example, ones like the felt padding. All of these should still go through your podiatry clinic or a wound specialist, but we will often put felt padding around the actual ulcer so that when they're walking on the sole of their foot, they're not going to put pressure on that ulcer. We may couple it or even just go with a Darko boot or even a cam boot, and then you have the knee walkers as well. Whatever we go with, the focus remains very simple: offload, so that we don't have to necessarily go down the path of further concerns for amputation. Now, in terms of how you could manage that wound bed for these types of wounds, sharp debridement is always preferred, unless, of course, there's ischemia, but by a trained person. And I'm talking about someone perhaps like a wound care specialist, a CNC, definitely a podiatrist. They're heavily trained in this area. You do need to get early referrals out so that we can come in and manage these patients quickly before it progresses. Just an important factor to note is that sharp debridement doesn't just happen once. You have to repeat it on a regular basis to make it work. In terms of dressings, this is my number one question all the time. What kind of dressing should I put on what wound? Well, the rules are the same for every kind of wound type. We should never put each wound type in a category of what dressing to put on it. We should flip that narrative and say, what are the characteristics I'm seeing in the wound to drive me to that dressing? For example, if it is excessively moist, I need something to drain that, to secure that moisture from getting too excessive and macerating the edges. If it's too dry, then I need to moisten it, because moist wound healing applies. There are adjunct therapies such as negative pressure wound therapy, particularly post-op. If someone has had an amputation, this will be our first go-to. Your sucrose octasulfate dressings. Hyperbaric chambers are fantastic if you've got one locally, or if you can refer that they're really, really great. And there's some newer products on the market, such as your placental derived products. And yes, not everybody has access to them. So what I would say here when it comes to what dressing do I put on these types of wounds is think about the characteristics, see what you have in your cupboard, because everywhere's different, and apply according to those principles. Now, recognizing infection, particularly, well, for any wound is important, but particularly for a diabetic foot ulcer is really, really crucial. And the rules are the same. If it's a local infection, there may be some erythema, often spreading by about 4 centimeters outside the wound. There could be swelling, there could be heat, there could be tenderness. When it's a systemic issue, we might start to see the patient having a fever, maybe tachycardic. They might have raised CRP. They might have the rigors where there's shaking. Where we start to become very, very concerned is signs of osteomyelitis. And again, this is where we would refer to our high-risk foot clinic or our podiatry services, because they'll do a test called a probe to the bone. And we can see here as well some raised ESRs or CRPs, and we will also look for X-ray changes. Osteomyelitis is a medical emergency, and it needs to be treated and managed quickly to ensure that we're not leading down the path of potential amputation, because we need to manage that infection that's now in the bone very quickly. There are escalation pathways in Australia, and we say that an urgent admission to hospital would be considered a grade 4, or in other words, a severe infection such as osteomyelitis. Immediate referral to the multidisciplinary foot service, such as a high-risk foot clinic, a podiatrist, a wound CNC, is often a complex moderate infection or a grade 3. So please refer to us or your high-risk foot clinic or podiatry service earlier rather than later, because we know that we can in fact save these limbs. So the overall pathway for your DFU patients is to identify and classify. So use the SINBAD, and again, today is a very much an overview, a very quick overview for a very complex wound type. So if you're not familiar with SINBAD or never used it, I'm sure if you did a simple Google search, it will come up and will walk you through, or head over to the Diabetic Foot Australia website to find those details. And consider then, classify the risk. Number 2, you want to offload. So maybe it's a Darco, maybe it's a felt. You just need to offload that wound. If the patient continues to walk on that wound, they are going to be in a very high category for concern for complications. You do want to debride within your scope, and I'm talking about sharp debridement, which is generally your wound specialist. So you can refer to us at Wound Rescue or your podiatry team. You do want to focus on moist dressing. So please, let's not stick these wounds out in the sun to dry. I mean, goodness, we haven't been doing that process for many years now. Perfusion, we need to check, and we need to check it at every dressing change. So take the pedal pulse. If you can have access to a Doppler ABPI or toe pressures, or refer to Wound Rescue, we'll come out and we'll do that for your patients so that we can determine if there's any vascular concerns. And if needed, make an urgent referral. Think about infection. Diagnose well. Do you need maybe a swab to be done? And then base your antibiotics treatment off the findings, because we know all about AMS. Education and prevention is key. Footwear and health literacy for the patient around managing callus through a podiatrist, looking after nails, you know, even the way they cut their toenails, tinea care and daily checks. I cannot stress enough, I would actually encourage this Wound Awareness Week. Make it your mission to every person you're seeing for this week, have a look down and check out their shoes and get an idea of what's acceptable and what's not. And if they're shuffling or their shoes don't look quite right, it's not acceptable. And if they have diabetes, they're going to potentially start to cause that shear and friction, callus, which can present into a DFU. Let's stop it before it begins. And in terms of red flags for clinicians, rest pain is a big indicator something is happening. There could be rapid spreading of cellulitis and systemic toxicity. The abscess could be quite deep, necrotizing infection or even gangrene. When it comes to ABPI and toe pressures, ABPIs below 0.5 and toe pressures below 30 are a huge red flag. So in terms of the essential preventative strategies, structure your education and self-care for all at risk is important. Appropriate footwear, I've gone on and on about. One of the things we always recommend for our diabetics, particularly if neuropathy is at play, is don't only wear your shoes indoors, but make sure you've got them outdoors. Think about culturally safe care. How can we involve our First Nations communities and how can we support their knowledge? Telehealth and outreach services are really important for our rural and remote communities as well, because, you know, Wound Rescue, one of our mottos is equity for all when it comes to wound care. So from today, my key takeaways are that Australia has close to around 10,000 amputations every year. The message here, guys, is that most are preventable. DFU is commonly a result from neuropathy and peripheral arterial disease and trauma. Offloading is absolutely key. Early referral to a podiatrist, a wound specialist, or a high-risk foot clinic is crucial, and regular reviews is even more important. And prevention relies on regular screening, appropriate footwear, and culturally safe education. And with that, I will hand back over to Sam, and thank you all very much for joining me today, and happy Wound Awareness Week.
Excellent stuff, Haley, as always. Basically, we're going to go through Angus's presentation now. Angus is from Smith and Nephew, who have kindly sponsored this event. So, Angus, take it away.
Thank you, Sam. Just getting myself sorted here. Okay, and a big thank you to Team Medical and to Haley from Wound Rescue for the opportunity to be able to present to you guys. What I'm going to do today is have a look at a tool that's used often for managing wounds, which of course are relevant to diabetic foot ulcers. Before I get into that, a quick overview of wounds. As you probably all know, there's over 450,000 chronic wounds in Australia annually. The cost to our healthcare system, and in fact, in general to productivity, is around $6 billion. And of course, the major wound types that you can see here are our pressure injuries, DFUs that we're talking about today, venous leg ulcers, surgical site complications, burns, and then there's others such as grafts, skin tears, etc. But the main focus today is, of course, on diabetic foot ulcers. So before I get into our time clinical decision tool, I wanted to remind everyone of the range of dressings that Smith and Nephew have, and the fact that, as you can see to the left there, all of these dressings are indicated for diabetic foot ulcers at various stages and for different reasons. So I'll get into those dressings a little bit later. So let's talk about the time clinical decision tool. Most of you will have heard of it by now, but it's a very useful tool for applying to how to manage all wounds, including diabetic foot ulcers. So the TIME acronym stands for, is the tissue non-viable? Is there infection or inflammation? How is the moisture balance in the wound? And is the edge of the wound advancing or not? And so we have a range of products at Smith & Nephew that can be used in those cases, which I can get into a little bit later. So let's start with the T. Quick reminder of what T is. It's the non-viable tissue, T for tissue, clinically observed as being non-viable. The pathophysiology is that there is a defective wound bed matrix and cell debris, which is obviously impairing the healing there. The wound bed preparation actions that we need to participate in at this point is, of course, debridement. So that can be episodic or continuous. That can also be autolytic, sharp surgical, mechanical, hydrosurgical, or even biological. And the effect of that wound bed preparation actions are effectively the restoration of the wound bed. That's what we want to achieve. And we want to achieve a viable, healthy wound bed. So a quick reminder of the I, the infection and or inflammation in the time. Obviously, clinical observations there is infection or inflammation, the redness and heat, etc. The pathophysiology is the high bacterial count and the prolonged inflammation. So inflammatory cytokines are present, there's increased protease activity, and there's reduced growth factor activity in the epithelium. And the wound bed preparation clinical actions are about removing the infected foci topical with focus on topical and systemic approaches. So antimicrobials, anti-inflammatories where necessary, and even protease inhibition. And the effect of those actions are that we reduce the bacterial counts or the prolonged inflammation. We reduce inflammatory cytokines, we reduce protease activity, and we increase the growth factor activity. And of course, we want to achieve a non-inflamed, non-infected wound. So quick reminder of M, the moisture imbalance. This is very, very important, and Haley referred to it. The moist wound healing principle is very much at the forefront. None of this putting it out in the sun to dry anymore. So obviously our observation there is some kind of a moisture imbalance, either too wet, too exudating, or way too dry. Those two can be described as either a desiccated wound. Most of you know that means a very dried out wound, which can slow epithelial cell migration. Cell migration likes moisture, or excessive fluid, causing the maceration of the wound margin, which can then exacerbate the wound in general. So our preparation clinical actions, the wound bed preparation, is to apply moisture balancing dressings and leave them on. And this is where the advanced wound dressing principle comes in place for all wounds, but particularly diabetic foot ulcers because they are very hard to heal. And also compression or negative pressure can be used depending upon the extent of exudate. If it requires the removal of fluid, this is where negative pressure can be very useful, and it can also help the edge of the wound, but I'll get to that in a minute. And the effect of those wound bed preparation actions are a restored epithelial cell migration, avoiding avoiding desiccation, avoiding that wound drying out too much, and edema and excessive fluid is controlled, and maceration around the edge of the wound is avoided. So obviously our clinical outcome is to optimize moisture balance. And finally, a quick reminder of the edge of wound, non-advancing, which of course is always a problem. So clinical observation is the non-advancing or an abnormal wound edge. So the pathophysiology is non-migrating keratinocytes or non-responsive wound cells and abnormalities in the protease activity within the wound. And the wound bed preparation clinical actions are, of course, if necessary, debridement to encourage the wound edges to start coming together and not be interrupted by poor material, skin grafts if and where necessary, some biological agents and adjunctive therapies such as negative pressure. Negative pressure can, by its nature, pull the edges of the wound together and assist with that edge advancement. And the effect of these actions are to improve the migrating keratinocytes and responsive wound cells and the restoration of appropriate proteinase profile in and around the wound. And of course, we would want to be seeing an advancing wound edge. So just reflecting back on those four principles of TIME, for the non-viable tissue, you could consider using the Smith & Nephew Intrasite or iodosorb, which I'm sure you're very familiar with. In extreme cases, our giant Versajet hydrosurgery debridement tool can be used. For infection, our Aleve & Silvers or Acticoat range are often used and very effective, as well as Durafiber, and of course iodosorb is also going to be very powerful using its iodine, which will last for a long time compared to your more traditional iodines. And of course, for moisture balance, we would recommend the Aleve dressings. They can stay on for 7 days and can be checked if necessary and repositioned because of the nature of the silicon. It will re-stick to the skin. And then, of course, if there's excessive moisture, we would consider using negative pressure such as Renesis or Pico. And again, with the edge of the wound non-advancing, the idea there is, of course, to use the Pico or Renesis range to help to pull in the edges of the wound. So let's quickly talk about the Aleve foam dressings. This QR code, by the way, if you wanted to access that takes you to the Aleve website where you can request a sample and more information on Aleve. So wherever you see that, that's its purpose. The main principle with Aleve wound dressings are that they're absorbent, protective, and gentle. Absorbent because of our hydrocellular foam core, which will help to retain the fluid, but even under heavy weight being put on the fluid, up to 150 kilos, it will retain moisture and it will help to minimize that risk of maceration. And then, of course, it's protective. The top layer is not only waterproof, but is a bacterial barrier, which is why it can be left on for 7 days. And they're very easy to apply and remove, minimizing pain and trauma. So a reminder, this is the range. We've got our Aleve Life, Aleve Gentle Border Light. We've got our adhesive and non-adhesive and silver ranges. Aleve Life is the 5-layer foam with a very high exudate handling capability, soft silicone adhesive, and can be left in place for 7 days or 5 days in the case of the sacral area. And patients are very, very content in using Aleve Life, as are healthcare professionals. Aleve Gentle Border is a 3-layer foam. It's the next step down, not as exudating wounds, but can be a little bit more flexible, can be cut for device-related pressure injuries as well. Is still shower-proof and bacteria-proof, and just can be a little bit more stretchy and has the multi-site option as well as the squares as well. And our Gentle Border Light, this is for, skin tears, but also for diabetic foot ulcers where the skin is very fragile, perhaps in elderly patients or diabetics in general, and is easier to remove and apply. And as I said, suitable for use on fragile skin. So without any more to say about Alleven, I would like to invite you to access this QR code and put in a request for a sample or other information at any time. And with that, I'd like to now hand back to, I think actually, sorry, I forgot I do actually have a video for you. Forgive me, Sam. This goes for a couple of minutes, so bear with me.
We know why you went into nursing. You want to provide outstanding care and attention, to make a difference. But we also know that these days it isn't that simple. There are more patients, smaller budgets, and fewer colleagues to pitch in. There are older patients with more complicated patients with higher expectations. And what's more, the cost of wound care has increased to 8. The result? It feels like everything is stacked against you. What you need is some from the foam dressings you use, and from the company that provides them. We're shaping what's possible in wound care. With our Alleven dressing, all the essentials you expect from a foam dressing, and more. Now it's possible to release time, waste less, and improve lives, including yours. With their extended wear time, along with their ease of application and removal, Alleven wound dressings work hard to give you back valuable time. You'll have more time to plan, time to talk, and time to care. With reduced dressing failures and 20% less packaging, Alleven foam dressings are also helping reduce the burden of waste and positively impacting the associated costs. Additional features include high conformability and comfort, as well as advanced lock-in and absorption technologies. And we know that what you really care about goes beyond the products. That's why we're offering you services and solutions that illuminate, aid, and support across the treatment journey. At the end of the day, it takes a great deal of innovation to be this simple. Basically, Alleven Life Foam dressings ease the worry for leakage. Essentially, Alleven gentle border foam dressings stay in place. And now, you can provide the care and attention your patients deserve. The care you wanted to provide from the very beginning. Alleven wound dressings. For what you really care about.
All right, Sam, back to you. And I think we're transitioning to Q&A.
Excellent. Bang on, Angus. And yeah, thank you for doing that presentation. Excellent work, Angus. We are going to dive into the Q&A with Hayley now. I do see that Hayley has very kindly answered some of those questions in the chat, but Hayley, if we're okay to go through them on this platform as well, just so everyone can hear them, that'd be fantastic. So the first question we have, are there funding options for diabetics to get appropriate shoes if they can't afford them?
Yeah, in terms of shoes and offloading devices, I've alluded to in the comments that it does depend on a number of factors. Do they have a scheme? For example, are they a Commonwealth supported community patient? What package are they on? And then it really comes down to what podiatrist is available. Are they a private practice podiatrist? So fees are really tricky when it comes to answering that question. My advice would be to ask up front. So if you're going to refer to a podiatrist, ask them what their fees are. If I may just jump straight in, Sam, to the questions around the Commonwealth scheme that we currently have. I'm proud to say that in my 5-year tenure as the chair of Wounds Australia, we really heavily advocated for a consumable scheme. And for anyone who doesn't know, that came into effect this year, whereby the Commonwealth federal government has actually provided $48 million to provide dressing products to any patient over 65 years living with a diabetic, living with diabetes and needs wound care products, or over 50 years for First Nation patients. Now, how long does it take to get the consumables? It depends on where you live. Some can take 2 to 3 days, some can take a little bit earlier, some can take a little bit longer. My advice there is order for a few weeks, because there's actually no clear guideline as to how far out you can order. So I'd always recommend order for at least 2 weeks so that your patient gets it, or even send it back to the GP practice. Now, I'm sorry to say, but if you are already covered by a scheme, for example, residential aged care or community services or NDIS, you can't access the scheme.
Haley. Fantastic. So another really interesting question I see here is in regards to pressure areas on toes. Did you have any recommendations for that?
In terms of pressure area on toes, there's a couple of things I'd say. Start with shoes. It's always back to the basics. What are their shoes like? Is it too tight? We always recommend if they do get any swelling by the afternoon, go with your Velcro shoes. Think about what they're putting on. If they are perhaps bed and chair bound, think about, are you using bed cradles? You do want to offload the pressure from the sheets even, because that will add additional pressure to those areas, which can break them down. And then inspect, inspect, inspect. We always recommend, if you can, twice a day or at least daily. And it doesn't have to be you as the health clinicians, particularly community. You may not see the patient every day. You might see them every 3 or 4 or 5 days. So involve the carers. And what I'm talking about there is their loved ones. Get them involved in doing the checking if the patient can't do it for themselves.
And I reckon we'll wrap it up after this one. Actually, no, we have a bit more time. A lot of questions coming through. The engagement's been fantastic. One of the struggles or challenges we indeed face from day-to-day wound care, patient and family members insisting effectivity on sun exposure on wounds. Has this worked before from your experiences in any way?
No, is the simple answer. And let me explain. The moment you put a wound, and any wound here, not just a DFU wound, in the sun and expose it to high levels of dehydration, you might as well put it in the Sahara Desert. You're going to dry it out. You're going to stop the migration of good cells. You're going to stop the moisture from being able to keep it hydrated. And at the end of the day, it's going to delay the wound. And the first thing your patients and family will say, but hang on, the exudate levels slow down. And they're spot on. It will slow that down. But at the same time, it's going to slow the healing because of the migration of those cells. So perhaps talk to them about the importance and where we are these days. If we think about it, 20 odd years ago, that was our number one suggestion: stick it outside, let it dry out. But we've learned and we've evolved over time, and perhaps talking to your patients about that would help.
I need to hear that advice as well, Haley. Last two questions. What is best for suspected deep tissue injury?
As in terms of dressings, or?
I suppose so, yes.
I'll open it up broadly then. In terms of suspected deep tissue, what is the best care? Don't get it in the first place. There's my cheeky answer to that one. But if I'm being serious here, is offload. Everything comes down to offloading. So not just putting a dressing on, not just sticking the area, perhaps if it's on the heel, into a boot which sits on the bed, which hasn't offloaded at all, truly offloading. So think about things like your heel lift boots that puts a bit of foam underneath the actual calf and then offloads the heel for the patient. Think about how you can position them in a chair or in a bed, or talking to your patients about offloading and not walking on it because it will break down. In terms of a product to put on it, you might want to think about, for example, a foam dressing, because if it does break down, and they often exhibit or characterize with a fluid-filled blister of blood, and so they may break. So you want something to capture that. So a foam would be a simple solution.
We'll do the last question now for you, Haley, and a rough answer is probably fine, or just where to find the information in relation to DVA cover, footwear prescriptions and costs. Do you have any info on that?
I can't go through all the costs because I'm not privy to that, but what I can tell you is DVA does have a list. My clinicians use that if we do have DVA patients come through to us. You simply need to call them. They will give you a list, a full prescription of what they can and can't do. They're supposed to do that. And so hopefully you can just give them a call and get that information to you. Hopefully that's helped. I don't know if that was too simple, but yeah, that's where we are.
Excellent work, Haley. So on the chat, everyone, you'll see a link from Yana to a quick survey. It will take about a minute to complete. Please take a quick moment to complete this, as your feedback helps us to make improvement and select topics for future webinars. Haley, thank you for the fantastic presentation. We hope this webinar has been valuable for all participants and those watching on demand. Tomorrow, you'll receive an email from Team Medical with a PDF certificate and a link to the recording. We're wrapping up for now, but feel free to complete the survey after the webinar ends. Thanks for joining us and sharing your feedback. Thank you, everyone.
Bye for now.
Thank you.